Let's see the patient box. We have a male 5-year-old accompanied by mother. The chief complaint states that he needs his checkup. In the background or patient history, this patient has Langerhans cell histiocytosis and he's taking two medications, vinblastine and prednisone. The current finding is that he has good oral hygiene. Now the question is, which of the following conditions might be radiographically mistaken for Langerhans cell histiocytosis? Is it fibrous dysplasia? Is it multiple myeloma? Is it osteomyelitis or sickle cell anemia? So let's find out. Now, Langerhans cell histiocytosis is a systemic malignant condition frequently identified in children. We will refer this to LCH. Now, when LCH impacts the oral and maxillofacial area, it is marked by unique punched out lesion. You can see we have a lot of punched out lesion which is observed mainly in the mandible and the skull. So, radiographic appearance of LCH is punched out osteolytic lesions seen in the mandible and skull. Also, such patients have severe periodontal disease with floating teeth. You can see in the next radiograph, okay, these patients have severe periodontal disease with floating teeth. It appears as if these teeth are floating, okay, because of the resorption. Now, fibrous dysplasia is a congenital anomaly characterized by expansion of the bone. Here you can see this section is expanded. Now, radiographically, fibrous dysplasia presents as a radio-opaque lesion with slight, mixture of radiolucent areas, okay, exhibiting a ground glass appearance. So this is not the right answer because this is not a feature of Langerhans cell histiocytosis. Remember, fibrous dysplasia has ground glass appearance, it is radio opaque and has diffuse borders. So this is not the right answer. Let's move on. The next option was osteomyelitis. Now, osteomyelitis refers to infection and inflammation of the bone marrow. On radiographic imaging, it appears as ill-defined, diffused radiolucencies and radioopacities, which is in contrast with the well-defined lesions you find in Langerhans cell histiocytosis. So this is also not the right answer. Moving on to the next option, sickle cell anemia. Now, sickle cell anemia is a genetic disorder that modifies the shape of the red blood cells. If you look at their periapical radiographs, you will find that sickle cell anemia shows a step ladder trabecular pattern, and these trabeculae are arranged horizontally. Now, if you look at the cephalometric radiograph, you will find hair on end appearance. It appears as if the hairs also are radiographed. So, on lateral ceph, you're going to find hair on end appearance. In periapical, you're going to find step ladder pattern. These are characteristics of sickle cell anemia. The third feature we are going to find in sickle cell anemia is absence of corticalization in the mandibular canal. So what do you mean by this? Now, in a normal OPG, if you look here, this is a normal OPG and this is the mandibular canal. You will find two radio-opaque lines. Okay, so this is corticalization. But in sickle cell anemia patients, you're not going to find these radio-opaque lines. So that means it has absence of corticalization in the mandibular canal. Now, this happens because sickle cell anemia causes bone marrow hyperplasia. That means the body overproduces red blood cells to compensate for anemia, which expands the marrow and causes the surrounding bone to resorb or thin out. So that is the third feature. But remember, none of these features matches with Langerhans cell histiocytosis, so this is also not the right answer. Now, LCH resembles multiple myeloma because if you look at the lateral ceph of both of them have punched out lesions. Can you see that? Langerhans cell histiocytosis and multiple myeloma. So we need a thorough clinical history and histological examination to accurately identify whether it is LCH or multiple myeloma. So multiple myeloma is the right answer. See you in the next one.